describing. Number one is the refractive error within the normal range for the child's age? The second part will be, will this particular child's refractive error emmetropize? Dr. Swati has also already deliberated quite a bit on even the first 3 to 4 months of life is about 2 diapers with a standard deviation of about 2. Meyer et al. They talked about screening of normal infants and observed these kind of refractive errors as you see here, right from the first month of life and analyzing till about 4 years. And they saw a gradual decrease in the amount of hyperopia from about 2.2 diopters here down to almost a reduction by 50% by the age of 4 years. The multi-ethnic pediatric eye disease study from the United States also noted some racial variations, and they found that the Hispanics were slightly more hyperopic than the African American population. Donald Mutty, he also analyzed changes of these refractive errors. You saw Dr. Swati also referred to this paper, and looked at the progression of the normal refractive error from the age of 3 months to the age of 9 months. And as you see here, most of the error at about 3 months of age is centered within about 2 diopters of hyperopia. There were very few myopes, less than 1 to 2% of infants are going to be myopes. And by the age of 9 months, a large part of this graph has shifted towards emmetropia, lower levels, and a few children will still remain hyperopic. As Dr. Swati already mentioned, most of these infants are going to have a very fast emmetropization right from the age of 3 months till about the end of the first year of life. And from there on till about 2 to 3 years of age, the emmetropization process slows down a little, but is still quite significant. And this process will continue a little more slowly till almost 5 to 6 years of age. And the average cycloplegic spherical equivalent decreases from about 2.16 to 1.36 diopters in the 6-month period analyzed by this study. And the components of ocular change, Dr. Swati has already listed some of these components which actually bring about the final change as far as the refraction is concerned. And as you see here, the axial length has increased by almost 1.2 millimeter here, but the refractive error has reduced over the same period, and the corneal power as well as the lenticular power have also reduced, compensating for the change in the axial length. And this is the study by Meyer which I was referring to, and this emmetropization process not only affects the hyperopes but also the myopes. So the whole process is geared towards reducing the refractive errors as the ocular tissues they grow. Now the next question which we need to answer is, will this child's refractive error emmetropize? It is also known from these studies that children with very high errors are less likely to fully emmetropize. And those who do emmetropize, they lose approximately half of their spherical equivalent refractive error in the first year of life. So you have some kind of a guideline that if the child's refractive error is reducing rapidly and is reduced by almost 50% by the end of the first year, that this child is probably going to emmetropize. And approximately one third between 9 and 21 months of age. There was also, in this paper, there was also a weak association between poorer vision and a higher non-cycloplegic refractoscopic error affecting this process of emmetropization. And finally, there is also an association between the lack of emmetropization and associated ocular deviations. Now looking at this graph from that same paper, there is a very high likelihood of emmetropization when the spherical equivalent at 3 months is close to 2.53 diopters. But this probability of emmetropization falls quite rapidly, so that if the child's refractive error is closer to 5 to 6 diopters, there is less than a 50% chance that this will finally emmetropize completely. And this is the weak association which I was talking about. When the visual acuity is worse than 1.25 logmar, the emmetropization process is slightly worse than when the acuity is better than 1.25 logmar. The next question then comes is, will this refractive error disrupt normal visual development? Now, studies have shown that in children with +5 diopter or more of refractive error, 25 to 43% will finally have visual acuity worse than 6/12, and 87% will not reach 6/6 final visual acuity. And there is also been noted an increased chance of monocular or binocular amblyopia in 1-year-olds with 3.5 diopters or more in 1 million, and in 4 years old, if the most hyperopic meridian is 2 diopters or more. So in the first year of life, the kind of magic figure which you are looking at is something like 3.5 to 4 diopters or more of isometric hyperopia. Those are the children where you need your antennas up, and you need to look at these children very carefully and at least partially correct them if possible. Now, a large randomized controlled trial of almost 8,000 kids, this is one part of the study, realized that children who were hyperopic in infancy were 13 times more likely to become strabismic, 6 times more likely to show measurable acuity deficits by 4 years compared to controls. And wearing a partial spectacle correction reduced this risk to 4:1 and 2.5:1 respectively. So the 13 times is reduced to just 4 times. So there is a significant improvement in the risk by wearing at least a partial spectacle correction. And the same thing in a pictorial graph. These are the non-treated patients. And you see they have a higher risk of both strabismus and poorer acuities, both line as well as letter acuity. And the treated hyperopes are quite close to the controls. So you can kind of bring the whole derailed process closer to a kind of a normalization by treating these kids. The second part of this study also realized that corrections did not affect emmetropization till about 3.5 years of age. However, both corrected and uncorrected groups remained more hyperopic than controls in preschool years. So the larger amount of deviations do not finally emmetropize so much that they are practically normal. And coming to the next question. Now, will prescribing spectacles improve visual function? Part of this you have seen yourself in the previous slides, that yes, you do have improvements, and supported by clinical evidence that high isometric hyperopia responds to treatment, although the time course of improvement may take a long time. Just a couple of days back, I was seeing a child who is finally now 9 years old, and when I've been treating her since she was almost 1 year old. And for so many years, right from the age of 3 years to 4 or 5 years, her best corrected vision would never go beyond 636, 624. But persisting with the corrections and at times also giving her occlusion for one eye which was slightly weaker. Now at 10 years of age, finally her vision in one eye is 6/6 and the other eye is 6/9. So it does take sometimes a long time for the vision to kind of get back on track. But the percentage of children whose final visual acuity and with spectacle correction, which was 6/12 or poorer, a significant reduction, ranged from 11% to, in some studies, as high as 50%. So you need to follow up these children very carefully and maybe be more aggressive in your follow-ups and your treatment if visual acuity is not improving the way we would want it to. And the final question to answer is, will spectacle correction somehow affect the process of demetropization? As I said, they did not note, Atkinson and colleagues did not note a significant difference, whether treated or not treated. But on a reanalysis of their own data, the compliant spectacle wearers emmetropized a little less than the non-compliant spectacle wearers or controls. So there was some effect, although it did not reach very high clinical significance levels. In other studies, when greater percentage of refractive error was corrected, lesser difference was observed between wearers and controls. So as you can see, there is some conflicting evidence coming from people. So this question is not yet fully answered. So you would lean more towards correcting high errors and preventing visual disruption rather than bothering too much about the effect on the process of emmetropization. In older children, the spectacle correction, once you are able to record vision in subjective terms, is a little easier. But again, there is no cross-board consensus on what to do for small refractive errors. You can prescribe small hyperopic errors as well, especially the ones where you have an association with asthenopia, difficulty. More than 5 diopters in the first year of life, you would want to prescribe, but nothing lower than that. Again, undercorrect because